Can everyone confirm if they're able to hear us?
Yes, I can hear you.
Yes, coming through clearly.
Great. Okay, go ahead, Peter, and if you can, and please continue.
Okay, I hope you can hear me. Sorry about that. And yes, so we then were able to allocate the 18 sites into 2 study arms. And these sites were located in the western part of Kenya and also in the Nairobi and the central region. And the intervention basically involved the partner services, we defined it, was tracing of the sexual partner and the enrollment, and HIV testing and counseling for the sexual partner, and the linkage to HIV care for the HIV infected sexual partner. And we were interested that at 6 weeks, we would then evaluate the partner for HIV testing, HIV diagnosis, and also the linkage to HIV care. And of course, as I alluded before, we were interested in documenting differences in social harms across the two arms. So essentially, in the immediate arm, we would enroll the index case, get names, contact information, including phone numbers of their sexual partner, and then we would go ahead immediately to notify those sexual partners of potential exposure to HIV. But then in the delayed arm, we would enroll the index cases, get information about their sexual partner, but then we would not notify those sexual partners until after 6 weeks. And the idea is basically in the delayed arm is to actually see whether there would have been any sexual partner who would have been notified anyway without our intervention. And as I mentioned before, we will be reporting outcomes at 6 weeks. Just to again mention that we at baseline in both study arms screened for intimate partner violence, obtained informed consent, and also collected information about the index and their sexual partner. And we excluded from participation those index cases that were below 18 years of age, and also those index cases that we deemed to be at high risk of intimate partner violence. Those that were deemed to be at moderate risk for intimate partner violence were enrolled into the study, but then they were subjected to special monitoring. In terms of our statistical analysis, we had estimated that we needed 60 index cases in each of the 18 clusters to detect twofold differences in the testing rates, assuming a coefficient of variation of 0.25. And we used generalized estimating equations with a Poisson link to for our primary and also for our secondary outcomes. So these are the results of our study. So as I mentioned before, we had 18 clusters, 9 in each of the study arms. And in these 18 clusters, we approached 1,760 index cases, of which we eventually enrolled 1,119. Approximately distributed equally across the 2 study arms. We followed these index cases at 6 weeks to document outcomes, and we have data for analysis for about 966 index cases. And the follow-up rate was fairly equal across those two study groups. Overall, the 1,119 index cases mentioned 1,872 sexual partners, 913 in the immediate arm and 959 in the delayed arm. And we were able to follow these partners again for the HIV testing outcomes and enrollment to HIV testing outcomes. And in particular, we also had a fairly good rate of follow-up in the study arm of about 94%. We didn't do a 6 follow-up visit for the partners in the delayed arm. And so these are the results. We had 550 index cases. This is the baseline characteristics for index cases. We had 550 in the immediate arm and 569 in the delayed arm. And generally we had a fair balance of characteristics across these 2 study arms, although you can see that there were more females in the delayed arm, and also that there were more index cases from the Nairobi and the Central region in the delayed arm. And so for the main outcomes, as I mentioned before, we had 550 index cases in the immediate arm and 569 in the delayed arm, and we documented in the immediate arm 392 sex partners who tested for HIV compared to 85 in the delayed arm, giving us an incidence rate ratio of 4.8. For the outcome of those that were testing for the first time, there were 81 in the immediate arm, 4 in the delayed arm, a 15-fold difference. For those that were HIV infected, we had 136 in the immediate arm, 28 in the delayed arm, a 5-fold difference. And also for enrollment in HIV care, there were 4.5 times higher rate of testing in the immediate arm compared to the delayed arm. We also documented HIV testing outcomes in this population. As I mentioned, we had 1,872 sexual partners, and we enrolled 1,305, of whom 60% of them accepted testing. Among those that declined testing, 40% of them, the largest proportion, declined testing because they already knew their HIV status, and so a small proportion only declined testing completely. And as we can also see that among those partners that tested positive, that accepted to test and tested positive, almost 11% had never tested before, and again, amongst all those that tested positive, there was a proportion that actually were not enrolled in HIV care. And in other words, if we actually do it differently, that amongst, in terms of the rate and the numbers that are needed to treat, and comparing again globally and also comparing across regions, we actually estimate that we needed just about 4.2 index cases to identify one sex partner that was HIV infected. And there were differences between the Western region and also the Nairobi Central region. That was statistically significant. Basically, you needed a lower number of index cases in the western part of the country to identify one HIV infected case. Similarly, there were differences between the rural and urban areas with just about 3 index cases that you needed to identify one sexual partner in the rural areas compared to about 4.5 in the peri-urban areas. Similarly, for the partners that are testing for the first time, we estimated that you needed just about 3.3 index cases. No differences across regions comparing Western to Nairobi Central, but comparing rural and urban areas, you needed a much lower number of index cases in the rural areas compared to the urban areas to get one partner testing for the first time. And in terms of intimate partner violence, just to recap that at baseline, about 11% of index cases self-reported to be at moderate risk for IPV, at just about 67 in the immediate arm and 59 in the delayed arm. And at 6 weeks, we collected data on rates of IPV, and as you can see, there were 37 new cases of IPV at 6 weeks and 54 cases of repeat IPV. We identified 2 IPV cases that we considered were possibly study-related, and 1 in each study arm. However, on digging further, none of these occurred really. They occurred actually before we were able to notify their sexual partners. So in essence, this is the first cluster randomized trial of APS services in Africa, and we feel that the strength of our study is that we had detailed sexual history. We were able to go out to the community to trace and test partners, and we demonstrate here that partner services are effective and feasible in an African setting, and this is adding to the body of evidence that we already have from other African studies. And we also have demonstrated that APS is safe, although we do feel that this question needs further evaluation. So I'd like to thank this big team that helped to support partner services, including Kerry Fagwa, who is the PI of the study, and also Matt Golden, who inspired all of us to work on partner services. Thank you very much.
Hey, thanks so much, Peter. Again, this is Vincent Wong, USAID Washington, and fantastic presentation, elegant design, some important results. I'm aware of the time. I'm sorry for the dropouts for the people that were having some technical problems, but we're going to promptly move on to our next presenter and then move to a question period. So keep putting in your questions into the question window. And our next presentation is going to be from Joanne Cook, City of North Carolina. That's in the United States, for those who don't know. And this will be the U.S. example of partner counseling and referral services. So take it away, Joanne.
Thank you, Vincent. Good morning and good afternoon. My name is Joanne Cook, and I am the Clinical Program Director of the UNC, the University of North Carolina's Acute HIV Program. And I want to thank you for the opportunity to share our experience with partner counseling and referral services. Partner counseling and referral services are part of the normal and routine HIV and syphilis follow-up in North Carolina. We primarily use the partner counseling and referral services for persons newly diagnosed with acute HIV. The state of North Carolina, like I said, does use it for counseling all HIV and syphilis diagnosis. There are 2 partnerships in this program, the UNC Acute HIV Program, and the members of our program are listed on this slide. And then there is also the North Carolina STAT Program, and the primary members of the North Carolina Department of Health and Human Services are listed as well on this slide. So the Screening and Tracing Active Transmission Program, known as the STAT program in North Carolina, has been in existence since 2002. And we have partnered with the state of North Carolina in the active transmission of HIV infection with people diagnosed with acute HIV. In this program, when it was initially started, we implemented expedited partner services and partner notification for this program. Typically, partner services are started about 7 days after notification. They need to notify people. For this program, the DIS, or the Disease Intervention Specialists, who work for the Communicable Disease Branch of North Carolina, they contact people within 72 hours of learning of a new acute HIV diagnosis. We were testing for acute HIV since 2002, and this is all done in the state lab in North Carolina. All HIV testing that is negative or indeterminate was screened for HIV RNA. And now with the advent of the combo testing for antigen and antibody, all the tests that are indeterminate, those are referred for additional testing for RNA. We also look at private testing done in private settings in North Carolina, doctors' offices, hospitals, and outreach programs. And if we note anybody who is diagnosed with HIV, we also initiate the partner counseling and referral services. We use the same principles that are used by the DIS for any HIV case, but we increase the priority and contact people within 72 hours. And this is often the first time they hear of their HIV diagnosis. They also prioritize partner notification, and they follow up closely with people who were diagnosed, people who they had sexual relations with within the 8 weeks prior to the test date. All this is done by the DIS across the state of North Carolina. Right here I'm showing you some information on some research that we've done in collaboration with the North Carolina Department of Health and Human Services Surveillance Department. And in this particular instance, what we did, that we saw that there was an outbreak in syphilis cases starting in 2013. So we combined the acute HIV partner services and contact referrals with the syphilis cases, and we saw that there was an increase in the number of acute HIV cases being found during these investigations, indicating that the high-risk nature of the networks. We also saw a high number of persons with acute HIV also having an STD or co-infections within a year of their diagnosis. Similar results were reported in research that was done by Anna Cope in 2014 and 2015, and by Christopher Hurt in 2012. Christopher Hurt in his research showed that the confluence of the high HIV prevalence, serodiscordant partnerships, co-infections with STDs, and involvement in a network created a risky environment in which any or few lapses in safe sexual practices led to HIV infection. This is RPCRS data from the acute HIV program for 2015. There were 83 cases identified across the state of North Carolina. There were 212 partners initiated, indicating about 2.6 persons per acute case. However, what is not accounted for here in this number are the number of internet partners that are identified with each case, and oftentimes we are unable to locate or trace those partners. Of these 212 partners, 61 were previous positive. Also not listed on this slide is that 29% of the people named were unable to be located, or if they were located, they refused testing. Of the 88 partners that were tested, a quarter of these people were positive. Again, showing the high risk networks that these people are associated with. And a third of the cases that were positive with acute HIV also were diagnosed with an STD at the same time of their diagnosis. This is just a slide that shows the demographics of the people being diagnosed with acute HIV in North Carolina. There are two groups here. One is the group that was detected through the community, and the other is the group that was detected through the state lab at North Carolina. As you can see, our population is primarily young, median age of 25, Black, male, with a risk for MSM. This is representative of the population in the United States most impacted by the epidemic. And what we've learned using PCRS and through the acute HIV testing program here in North Carolina is that the interviews and the actual meeting with the DIS after the infection is very effective for accurately assessing risk assessments. Folks were more likely to explain or tell their risk factors to the DIS than they were to report at the time of testing. The people who are being found to be positive with acute HIV are also predictive of the epidemic in North Carolina, the young Black African American men or young Black men of color. Naming partners and with contact tracing was an effective way to increase testing. 42% of the people named were newly tested. Internet hookups or people that were partners and found on the internet restricted the access. We have restrictive access to these forums, so therefore it makes it very hard for us to identify who the partners are, and therefore at times we are not able to locate these people or to refer them for further testing. The contact testing, we have found that when a person is notified quickly of their HIV, that they oftentimes will notify their partners, and they will also give the names of the partners to the DIS. And in these scenarios, there's a very effective and a high yield of partners who are tested, and the DIS can follow up on that. And those that refuse to cooperate when they are contacted, and they refuse to name partners, but they say that they will contact those partners. This disrupts the contact tracing and partner notification because there's an inability to follow up on the testing of these partners. And in North Carolina, HIV notification may only be done in person. So that's what we have learned here in North Carolina, and I think hopefully I may have gotten you back on track because I spoke so quickly. So thank you very much.
Thank you so much, Joanne, for giving us the perspective from North Carolina and your experience there. I think there is a new term for many of us, internet partner, so a different way of looking at tracing. I think that was really interesting. Some questions even came in on it. We're going to actually extend this webinar about 5 minutes to get a few questions out there to the presenters. I want to reinforce that all the questions will be answered via the community of practice, the HIV testing community of practice. So if you're not on that, please link in on that after the webinar. The link will be on the last slide. And so we're going to start with the first question for all presenters from Shanti Conley. Could the speakers address any differences in the experience of notifying casual versus stable marital partners? And maybe start with Maria.
Okay, thank you. So we did do qualitative analysis. We have in-depth interviews from our index clients, which we have analyzed, and I didn't present in the presentation at all. But what I'm familiar with the transcripts. So just speaking about that, I would say that there was not a major difference. We couldn't isolate major differences between casual and sexual partners and stable sexual partners, but the majority of our index clients reached out to stable or marital partners. So most of our information is from folks who reached out to their sexual partners, their marital partners. But in general, we did find a relatively low described rate of negative consequences for the index clients. And we also interviewed sexual partners. And we heard a lot about about shock, feelings of shock, feelings of anger, but not really expressions of anger. And because our sample really tended to be couples who are looking for a facilitated disclosure, we did hear a lot of sort of a cycle of being shocked, dismayed, but then coming together as a couple to come in and to link to care and treatment, a sense of concern about the partner. The index clients cared enough about their partners to notify them and to try to link them to services. So we actually saw a relatively low rates of actual intimate partner violence or very profound negative experiences, and we couldn't distinguish that by casual versus marital.
Okay, Peter or Joanne, do you have anything else to add to that, to answer that question?
Thank you. In our study, 60% of sexual partners were regular partners and 40% were casual partners. We haven't sort of analyzed any differences between those sort of type of sex partners, but I think anecdotally from our health advisors, research assistants, the regular partners were really very keen to know how we got the contact information, their contact information, and trying very much to really identify the index. And of course, we had to be very tactful about that so that we didn't have to reveal the identity of the index case.
Hi, this is Joanne. For our notification and with our program, we find that most likely partners are likely to tell their partners. Casual relationships are usually handled by the disease intervention specialist, and I would say that most of the people diagnosed that we see have more casual relationships than being in a permanent relationship.
Great, thanks everybody. And I'd also note on that point, at least in the Brown study, they only had success at reaching primary partners. So I think reaching out beyond the primary partners is going to take some more explorations and how best to do that. The next question is going to really combine a number of questions. This has come up probably in about 4 questions, and that is legal policy issues around partner testing and disclosure. So are there legal issues that have arisen in your examples around the notification of partners of positive persons, and what are the HTC or testing policy implications around non-disclosure and disclosure of serostatus, if that in fact plays a role? So we can start with Peter on this one and then go to the others.
Thank you, Vincent. In our study, we didn't experience any legal challenges around how we notified our sex partners. But just to inform you that in Kenya we do have the HIV Prevention and Control Act that clearly specifies, of course, that confidentiality is paramount, that consent is required, and so. I think within those confines, then we felt that we were very well within the legal requirements. Our HIV testing guidelines also do reiterate that you can only, inform sex partners of the HIV exposure with the consent of the index case, and that's exactly what we did in our study. All index cases consented to give us names and contact information of sexual partners. Yeah, and I think it is a standard. I think even from normative guidelines from the UNAIDS, etc. Thank you.
Hi, this is Maria, and of course we worked with the Ministry of Health in designing the study, so We looked to them for guidance on what was appropriate and legal. But in our study, because so many, it was mainly passive disclosure, which means that the index client themselves were talking to his or her partner. So that wouldn't get us into, it seems like the approach was, wouldn't get us into legal concerns. That's the index client's choice to disclose to their partner. For the provider the provider notification, sexual partners would only be informed that they may be at risk for HIV infection, and that their presence for HIV testing was recommended. So there was no disclosure of any personal information. So the ministry, our ministry colleagues, when designing the study, felt comfortable that that was within the limits of Tanzanian law.
In North Carolina, we have state laws that govern how we can follow up with people who have HIV. So we would basically, the DIS act in that manner under the law.
Okay, thanks everybody. So, I guess to reiterate, I think in all cases, any testing, even in the context of partner notification and linked HTS, would adhere to the minimum standards established by normative bodies like WHO. So, primary being confidentiality, consent, and counseling. So that doesn't change irrespective of the result. We're going to end with a final question to the participants. And this is going to be on any negative outcomes that you've experienced. I know it's a question that's come up a few times here, and I know that there's a lot wondering around, as you implemented this, have you seen any negative outcomes at all? So I'll turn it over. Let's start with Mariah, then go to Peter.
Thank you, Vincent. Of course, this is a very important question because we're all concerned about rollout with rollout of partner notification, what negative reactions, what IPV might occur. We, as I mentioned, tried to screen for using the two-stage screening, and we were surprised at the low number of people. I believe it's much lower than what Dr. Cherutik describes in his study in Kenya of people who had potential for intimate partner violence. Only 6, so less than 1% of our participants appeared to be at risk for IPV and were not included in the partner notification. So that may or may not have been an effective screening tool, and we're very happy to hear others' experiences with screening out for IPV and partner notification. However, in terms of the negative reactions, both in the qualitative interviews that we conducted and through surveillance of our study group, we did not have major negative reactions reported. We heard a lot, as I mentioned earlier, of shock, some anger, but no major incidents.
This is Peter. So in our study at baseline, there are about 3% of index cases who reported to be either at moderate risk or high risk for IPV. And again, this is sort of lower than what we know to be the norm in the region. And we probably believe that, the way our health advisors asked the question was such that they were sort of screening out, or rather they were underestimating the way they answered the question may have underestimated the real proportion of people. And of course, in our study, we screened out those at the highest risk for IPV. And I think, as I mentioned before, we really had only 2 cases that could have been potentially related to the study, one in each study arm, and the numbers were too small to really perform any statistical test. And in our conclusion, we still feel that I think as we scale this up, I think it's still very, very important to have a tool that continues to monitor intimate partner violence, because again, our numbers were a bit too small to really perform a proper statistical analysis.
Thanks, Peter. And Joanne, any North Carolina examples of negative outcomes?
I was just trying to think if I have ever heard of any. I've been doing this in the past 14 years, and I'm sure they exist, but they're rare. I haven't heard of any negative consequences. I think the biggest negative consequence would be because of our state laws, and like people who are HIV positive, once they're informed, they're required to let their partner know that they have HIV and use protection. And so I think lots of times people, when they get notified by the DIS, they avoid them. And there's avoidance, of informing the DIS of all their partners and things like that because of state laws. But I don't have any cases where I have seen any violence or negative outcomes from people being contacted.
Okay, thank you, everyone. As we wrap up, I just want to first of all thank all of the speakers, Maria, Peter, and Joanne, for sharing their experiences with us all and helping push our thinking forward on partner notification issues related to HIV testing. Please note there's a poll in your window now. Please take that. That helps us improve our services. And also, we will be answering the rest of the questions over our community of practice. So if you're not a part of the community of practice, please link on that link in the display in front of you as well. Thank you all once again for joining us for the webinar today. And we look forward to having future webinars that also have a high level of participation.